and dive right in. Thanks so much, everybody, for joining us this afternoon. We're really glad to have you here with us. We've got some amazing clinicians who have joined us to really just dive into the topic of cardiac care in Duchenne. So for those of you who don't know me, my name is Rachel Schrader. I am PPMD's Vice President of Clinical Care and Education, and we are going to dive into cardiac care and do a Connect with the Experts today and answer all of your questions. Essentially what we're going to do, we're going to have a handful of brief presentations from our three clinicians. So we have Dr. John Soslow of Vanderbilt, Dr. Catherine Gambetta of Lurie, and Dr. Chet Villa at Cincinnati. Each of them will present for a few minutes, and then once those formal presentations are complete, we'll go ahead and transition into the live Q&A version. So please send us your questions through the chat function, and we will get through as many of them as we possibly can. That little chat function, if you're not aware, should be in the bottom center of your screen. So send those questions into us. If you have a question for a specific physician, go ahead and note that. And if we find ourselves running out of time and unable to answer any of the questions that have been submitted, we'll be sure to follow up with you afterwards. So let's go ahead and just dive right in. At this point, I'm going to go ahead and turn it over to Dr. Soslow.
All right, great. Thank you for inviting us to speak. And I'll be talking about cardiac imaging in Duchenne muscular dystrophy. So if you go to the next slide, I just wanted to start with the problems that we're faced with, primarily imaging problems. And the biggest thing is there's just no established clinical outcome measures or biomarkers in DMD cardiomyopathy. So there's no agreement on endpoints for cardiovascular trials. Left ventricular ejection fraction and myocardial strain have been used as biomarkers, but only a small number of trials have been performed. And the FDA has essentially told us they will not allow either biomarker currently as an endpoint for development of novel therapies. So we don't have an option for medications that aren't officially approved for cardiac trials. There's also the problem that DMD cardiovascular disease has a lot of variability, and that we need to start medications early in the disease for greatest efficacy. So it's not reasonable for us to do a 5 or 10-year trial looking for ejection fraction decreasing way down the road. So we really need surrogate outcome measures for these trials. So next slide. So the goals of our research program have been to identify biomarkers that can be used as endpoints in clinical trials, and to look for biomarkers or genetic variants that predict progression, so that we can risk stratify patients when entering clinical trials and reduce the total number of patients enrolled. So if you go to the next slide, we've spent a lot of time on this current multi-center study. It's FDA funded and PPMD supported, and it's at 6 sites around the country listed here. And we're enrolling patients prospectively and doing MRIs every 3 years along with other testing to really try to get a better sense of what that cardiac progression is in Duchenne muscular dystrophy. And I wanted to say that there's a similar trial that I'm not involved in, but I know a couple of the people doing it at Nationwide looking in carriers, where they're looking at longitudinal progression of carriers and trying to find the same thing. So if you go to the next page, back one, I guess. So we'll jump into the imaging, and it looks like we're having, sorry, we're having some trouble with playing the video. I should know better than videos in my slides. The echocardiography really is the standard in clinical practice for pediatric and adult cardiology. It's easy to obtain, it's available, everybody has it. But in Duchenne patients, it can be limited by acoustic window. So in this patient here, I don't think you can see my pointer, but you can see that circle there is the left ventricle, and you can nicely see the endocardial border, and we can get a sense when it's moving that this heart has normal function. And this is a Duchenne patient with nice echo windows. But if you go to the next slide, because of various factors, including scoliosis, adipose tissue, and positioning, the picture here is what we often get on echo. So we cannot see the walls of the heart as well. We can't get a sense of the function as well as we'd like. We can get a general idea, but some of our measurements that we perform routinely, we just can't do as the imaging windows degrade. So if you go to the next slide, cardiac MRIs become one of the mainstays in management for Duchenne patients. This is because there are no concerns with acoustic windows. It is the gold standard in all patients for left ventricular ejection fraction. And we can look for scar and other changes in the heart using something called late gadolinium enhancement. There are a lot of challenges with MRI. Patients can get uncomfortable, especially if they have a lot of contractures, and then they have to lie there for a little bit longer period of time, usually up to about 45 minutes. They have to hold their breath, and they have to lay still, and their heart rate variability can affect the quality of the scan. So not everyone can undergo a cardiac MRI, and we certainly have patients who we are not able to do because they're claustrophobic or because they can't fit in the scanner anymore because of contractures. So next slide. So a while back, we looked at the correlation between MRI and echo just to get a sense of how well echo is working and what measures on echo work the best, because we have a lot of ways of measuring function with echo. And so this was in 28 patients who got an MRI and an echo, most of them on the same day. And when you look at these numbers, the only thing that is important is that the higher the number, the closer the number is to 1, the better the correlation. And you can see that for at least these 4 measures, the correlation was not particularly good. We really want 0.7 or above for these measures. And so these measures of echo function really didn't correlate well with MRI or the gold standard. If you go to the next slide, however, there were 2 measurements, this 2D fractional shortening and bullet EF, which are standard measures that we use in echo. Those did correlate the best with cardiac MRI. And so in patients in which they were measurable, we recommended that these be performed, and that's what we use routinely in our clinic. The other thing I want to point out, because I think it's been overlooked by, at least by reviewers on other manuscripts and some other investigators, is we were pretty careful to point out that in the setting of satisfactory imaging windows, both methods are fine for routine functional evaluation and screening. Obviously, MRI adds value because we can look for scar, and it adds value in patients who have bad imaging windows. But if the windows are adequate in patients who are unable to undergo MRI, this is a fine method for screening. The only time we really felt like MRI was always the best option is for research projects where small differences need to be measured. So if you go to the next slide. Now, we're really interested not just in LVEF by MRI, but also some of the other more novel methods we can use to assess function and myocardial changes. And this is an example of what we call parametric mapping, which can get a look at the myocardium and really get a more detailed assessment of what's going on. So this is late gadolinium enhancement, or LGE, that we discussed earlier. And this is a healthy control with a normal evaluation. And then the second one in panel D on the left is a patient with Duchenne muscular dystrophy and kind of the standard late gadolinium enhancement pattern we see. The arrows are pointing out those white areas where there's scar. And then on the bottom is a patient with Duchenne's without delayed enhancement or late gadolinium enhancement. Now we can use something called T1 mapping or ECV mapping to get a sense of the scar or fibrosis in the myocardium. And that scar is visible here in that ECV map in panel F, in the same place that we see the scar on the delayed enhancement imaging. And then the T1 is also elevated in that patient. So it does correlate with those findings. The other thing that we found, though, is that in some patients with Duchenne, they have no delayed enhancement as in panel G, but they have abnormal T1 and ECV, which suggests this is an early finding in patients before they develop delayed enhancement or LV dysfunction. And it's something we can use to find these earlier changes. If you go to the next slide, when we looked at the cohort we enrolled, we looked at just the ones with a normal cardiac MRI by our standard measures. So normal function, no delayed enhancement, no late gadolinium enhancement. And those patients had higher T1 and ECV compared with controls. But you can see in that scatter plot that not everybody was abnormal. So this does give us a way to look at differences that may start earlier. Next slide. So we've also used this for category, sort of almost like a virtual biopsy of patients. And this is something we presented as an abstract a few months ago. But if you look at these metrics, you can try to categorize patients and get a sense of how this progression is happening. Since we don't have the ability or we don't really have the desire to get biopsies in any patients. And so we really don't know as well the progression of myocardial changes. And so in this study, we looked at all of these parametric mapping measures and kind of tried to classify them in different groups. And so the light blue patients were completely normal. The dark blue patients had T1 elevation, so we were calling them early scar or edema, probably scar in this situation. The red patients had early scar formation. And then the green patients, actually, we saw edema based on the elevated T2 time, suggesting that inflammation was a part of this progression and disease process. And we saw many more patients with edema than we expected to see. And then the orange and yellow patients had some fatty infiltration. And both the fat and the edema are not surprising given what we know about the skeletal muscle progression, because they get edema of the skeletal muscle and they get some fatty infiltration. But we hadn't yet really shown this as well as we would have liked. And so this kind of method can be used to really get a sense of how these hearts are progressing, and hopefully give us some insight into what the best medications will be down the road to help prevent some of this progression. So next slide. This is a paper by Siddiqui et al. From Cincinnati, and it's a nice paper looking at myocardial strain. The two different subjects are those pretty much age-matched patients, those who developed cardiomyopathy and those who didn't. So the ones who developed cardiomyopathy are in red, and they were all caught or all found sort of when their ejection fraction was normal. And what these authors found was that those with strain that was abnormal, whether two-dimensional or three-dimensional, were more likely to progress to become to cardiomyopathy, whereas those with normal strain were less likely to progress. And they used this. They used multiple different strain methods in order to show this. There's a really nice look at sort of earlier findings that may predict who's going to progress to LV dysfunction. And if you look at the next slide, this is some work we've been doing looking at progression of disease and also progression to mortality. And so we looked at a large cohort of patients and tried to figure out out of a huge number of biomarkers, kind of as a pilot study, what would predict long-term outcomes, and showed something similar, that ejection fraction and strain really seemed to be the best of the cardiac MRI biomarkers for some of that long-term progression. And so next slide. So conclusions, and then I'll pass it on to Catherine. Echo and MRI are the most commonly used imaging modalities in Duchenne. MRI definitely has advantages over echo, especially the late gadolinium enhancement and some of the new markers we're looking at, but echo can and should be used for clinical decision-making when MRI is cannot be performed. And then advanced MRI metrics are helping us better understand and predict progression of disease. So thank you, and I'll turn it over to Catherine.
Hi, everybody. I'm sorry. I'm late. We're out of sequence, so sorry about that. Hi, so I'd like to thank Rachel and PPMD for giving me this opportunity to talk about Duchenne muscular dystrophy in the heart. I'm one of the cardiologists at Lurie Children's Hospital in Chicago, and I go to the MDA clinic there. And I love the families I take care of, and I'm always inspired by their resilience and strength. Next slide. So today I wanted to talk about the importance of dystrophin in the heart. I wanted to talk about the natural history of cardiomyopathy, and then also to discuss the medical management of the heart as well, but specifically focusing on early management, as Dr. Villa will talk more about the advanced cardiac therapies. So as we all know, survival and neuromuscular function and quality of life are improving currently due to our advances in respiratory support and the use of steroids and different spinal surgeries. So now children diagnosed with Duchenne muscular dystrophy are surviving into their 20s and 30s, and some even later. But as kids are surviving more and more, cardiac disease is increasing as a major cause of death and is presenting as cardiomyopathy and cardiac arrhythmias. So what can we do to change this? And I think to change this, we need to kind of backtrack a little bit and look at what is the root of the problem. And as we all know, with children with Duchenne muscular dystrophy, there are mutations in the dystrophin gene. And we know that the dystrophin gene is one of the largest genes in the human body, and it covers about 2.5 megabases. This gene provides instructions for making a protein called dystrophin. And this protein is primarily located in muscles, but it's also located in other organ systems as well. It's located in the skeletal muscles, heart, and brain. There are 79 exons, and there are 8 promoters, and there's about 99.4% introns. There's an N-terminal actin binding site that binds dystrophin to actin, and there's also a raw domain, which gives dystrophin its flexibility. And there's also another end called the CTD and CRD, which stands for cysteine rich domain, which also helps anchor the protein. So, so dystrophin attaches the actin to the muscle membrane, and it's important because it provides stability to the muscle when it's contracting. It's also important in cell-to-cell communication, and it's important in different other pathways like nitric oxide synthase. So it's a very important protein that's present throughout the body. In terms of how it affects the heart, how does it translate to the heart? Can you go to the next slide, please? So in the absence of dystrophin, this dystrophin-glycan protein connection becomes destabilized, and it disrupts the integrity of the membrane itself. And when it disrupts the integrity of the membrane, it allows for an increase in intracellular calcium, which leads to the development of proteases that get activated, and that causes more degradation of contractile proteins. So in this diagram, you can kind of see what happens when you have this abnormal dystrophin protein. You get death of the cardiomyocyte, which is the heart muscle cell. And then as a response, you get increase in inflammation. You get fibrosis formation. And as a consequence, since healthy muscle is being replaced by fibrotic tissue, you get stretching and thinning of that fibrotic region. And so in the heart, what happens is that in the left ventricle, since the walls of the left ventricle are becoming stretched and thin, you get an increase in left ventricular volume, increase in wall strength. You have abnormalities in how the heart muscle contracts and stretches and relaxes. Oops. And as a consequence, you have decreased contractility, decreased cardiac output, and some of the valves start leaking as well. Can you go to the next slide? So I'm not sure, I had like a video appearing here. Is there a way that I can change this, or if you can click on the video, I guess, or the slide behind it? Sorry. Can you click on the pink looking slide? Okay, well, I had like these different images that were going to appear at different times. So basically what happens is you have myocardial muscle that's replaced with fat and fibrosis. And so there's a picture in the back where you kind of see like these the pink purplish areas. That's actually like heart muscle. And basically what happens, that gets replaced by fibrotic changes. And so the purple, the bluish looking paler areas are signs of fibrosis that we see on microscope. The fibrotic changes usually sort of start appearing like the base of the heart, and it kind of proceeds down towards the apex of the heart. And as a consequence, cardiomyopathy develops. And cardiomyopathy really refers to chronic disease of the heart that eventually leads to heart failure. And there are different stages of cardiomyopathy. Heart failure refers to the inability of the heart to meet the metabolic demands of the body. And as cardiomyopathy progresses, heart failure continues and worsens. So in children with Duchenne muscular dystrophy, cardiomyopathy increases as the child ages. Usually by around 6 years of age, it can be seen in about 25% of children. By the time children reach 6 to 10, about 59% are affected. And then by adulthood, nearly 100%. As a consequence of cardiomyopathy and heart failure, arrhythmias may occur also as cardiomyopathy progresses. And arrhythmia refers to abnormal heart rhythms. And abnormal heart rhythms can take the form of ventricular tachycardia, supraventricular tachycardia, and sometimes these arrhythmias can progress to the point where a child is at risk for sudden cardiac death. And so There on the right side, you see an EKG tracing of a child who has Duchenne muscular dystrophy. And what we see are normal heartbeats followed by these fast heartbeats that occur. Can you go to the next slide, please? So, so the natural history, so this diagram I thought was really nice because it showed really what the natural history of the progression of cardiomyopathy is in children with Duchenne muscular dystrophy. And so it shows that when a child is first born, they have a normal heart. And so you see like a normal heart on the left side. And then as they get older, they progress through this timeline. So there's a preclinical stage when a child doesn't have symptoms of heart failure. And that's usually between the ages of 0 and 10. We do see sometimes some changes like on the EKG, and sometimes you can see some minor subtle abnormalities on the echocardiogram. So you do see some changes then, but they're not overt changes, and usually the child doesn't have symptoms at that point. And then by the time children are around 10, you will see more changes where you can see some evidence of fibrosis that Dr. Soslow was talking about on MRI. Sometimes you'll see some progressive dilation of the chambers where the chambers become enlarged. And sometimes some children will start developing symptoms. Then by the time children are like young adults, most often they will have definite overt signs where you will see decreased heart function, you'll see an enlarged heart. Sometimes you'll already start seeing arrhythmias. And generally by this time, children will start having some symptoms of heart failure like fatigue, dizziness, lightheadedness, palpitations. Sometimes some kids have very bad abdominal pain and inability to tolerate feeds. And then as time goes on, they'll develop end-stage heart failure. And heart failure, unfortunately, is the cause of up to about 40% of deaths in children with Duchenne muscular dystrophy. So, so this kind of leads us, since there's this natural progression, is there any way that we can intervene on any of these on any of this scale for children? Is there any way that we can intervene to kind of help at least prevent things from happening, or at least delay the development of children developing cardiomyopathy? And so that's where we're trying to focus our cardiac treatment in. Could you go to the next slide, please? So in terms of management of how we do this, there have been several guidelines that have been published. There have been several guidelines that have been published. One has been published by the American Heart Association, another by the American Academy of Pediatrics, and then one with Lancet. And these have been published in the last 5 years. And then there's also another network called ACTION, which stands for Advanced Cardiac Therapies Improving Outcomes Network, and Dr. Bill will talk more about that as well. But it's also a multi-center group that consists of doctors and researchers and parents and patients as well across the country, with the goal of improving outcomes for children with heart failure caused by many different things. And so one of the goals of the ACTION group is to kind of compile all these guidelines and for children with Duchenne muscular dystrophy, especially since there's been so much variability in how we practice, and so many things have changed in the past 10 years. So the goal is to kind of unify how we manage children so that we can kind of find out what works and what doesn't, and it provides for better collaboration so we can help children have the best life possible. Go to the next slide, please. So I'm going to be now focusing on our early medical management recommendations. And so, so first of all, when a child is diagnosed, all patients should have an initial cardiac evaluation with an exam, EKG, and imaging performed at diagnosis. So I recommend an echocardiogram to be done. And generally what's recommended is that evaluations be done every 2 years with an EKG and an echo in children who have no symptoms, and if they're less than 10. However, once they're after 10, these evaluations should proceed annually. However, if there are signs of dilation on the echo, dysfunction, or arrhythmias, or if we're concerned about anything with a child, then the provider may want to see them more often. So, so generally for now, if you're asymptomatic, if a child's asymptomatic and doing well, to be once every 2 years until the age of 10. Then another recommendation is to consider advanced cardiac imaging with MRI to look for fibrosis as well as to look for function. And so generally what I recommend is that once a child is able to do an MRI without sedation to get that MRI. Usually kids are able to do that around the age of 8. And the reason is that the MRI takes a long time. It takes about an hour to do, and the child has to kind of do certain breathing maneuvers during the test, like hold their breath and follow instructions. And so sometimes it can get very tedious for a child to do it just because they're there for such a long time in the scanner. And so I like to do it when kids are able to do it without sedation. Sometimes MRIs are done with sedation, but I prefer to do one without sedation just because there are risks with sedating a child who has neuromuscular disorders. Like there are risks with waking up from sedation because of their respiratory weakness. So that's why I kind of feel like once a kid's mature enough to do it, then to do it at that moment in time. Routine EKG monitoring is recommended at least every 1 to 3 years based on their age and cardiac function. So I would say if you're less than 10 and you're coming in every 2 years, I would get an EKG. If you're over 10, I probably would get one every year. And then of course, if I'm concerned about anything from a heart perspective, I would get it more often. And then the other recommendation is to consider periodic ambulatory Holter monitoring. And so what this refers to is a monitor that a person will wear that records their EKG for a 24-hour period. And this is done to assess for arrhythmias and also to kind of see what their heart rate trends are, because children with Duchenne muscular dystrophy can also have some autonomic instability of their heart rhythm, and they may have higher heart rates. So it'll be nice. So it's nice with the monitor to kind of trend their heart rates. Could you go to the next slide, please? Thank you. So this next diagram is just talking about how we manage heart failure. And so we use the same medications that we use to manage heart failure as we do for children with Duchenne muscular dystrophy. And so the primary targets for heart failure are medications, and I'll be talking about each of these medications as we go forward. But the medications that we commonly use are ACE inhibitors, beta blockers, digoxin, and they act on the heart and the kidneys and on the peripheral vasculature in different ways. So ACE inhibitors are a common stay of our medications, and so I'll talk about that next. Could you go to the next slide, please? So, so one of the first line agents that we use for children with Duchenne muscular dystrophy are ACE inhibitors and angiotensin blockers. So ACE inhibitors are a great medication. They are a medication that decreases the vascular resistance that the heart has to pump against. They also decrease wall stress, and they do have some remodeling properties. So the goal is that they can sort of hopefully ameliorate some of that fibrosis that can occur. So when do we start these medications? And that's been a question that we've been kind of thinking about a lot for the past few years. And so there are studies that are showing that starting these medications prophylactically can appear to slay or delay the development of cardiomyopathy. So also, they're finding that starting these medications in people who have normal function and signs of that fibrosis and EKG on MRI can also help slow the progression of disease. So, so the existing guidelines are now to at least start the medications on all children, at least by the age of 10. So I tend to start them a little bit earlier by the age of 8, but guidelines are just to have all boys and children with Duchenne muscular dystrophy started on these by the time they're 10 years old. Now, if there's signs of heart dysfunction where the left ventricular ejection fraction is less than 55%, or the shortening fraction is less than 28%, or if there's signs of LV dilation, I would also recommend starting the therapy with either an ACE inhibitor or an angiotensin receptor blocker. And so some examples of ACE inhibitors that you've probably heard of are lisinopril, perindopril, and enalapril. And some examples of the angiotensin receptor blockers are valsartan and losartan. Now, these medications are great for the heart, but sometimes they can cause some kidney problems like elevation of potassium, or if somebody's very dehydrated, it can sometimes lead to rises in their kidney function. So I do recommend having some type of monitoring with a basic metabolic panel that will measure their B1 and creatinine, but also a cystatin C. And then also one of the side effects of these medications is it can lower the blood pressure. And we don't want to lower the blood pressure too much. We want to try to get that right blood pressure. So I do recommend routine monitoring of blood pressure just to make sure that the child is able to tolerate the medication well. Could you go to the next slide, please? Thank you. So the next medication that you may have heard about are beta blockers. And so beta blockers are recommended for children once they have systolic dysfunction that we see on echocardiogram or MRI. So generally, these aren't always so generally beta blockers aren't started first line. They're generally started once the child starts developing signs where we're worried about their heart. And generally that's recommended when the ejection fraction is less than 55 as well. However, it's also reasonable to consider starting a beta blocker if a child shows signs of having an abnormally high heart rate, like sinus tachycardia, or patients who have such high heart rates that they're having problems with it. And examples of beta blockers are carvedilol and metoprolol. Other medications that are considered are mineralocorticoid receptor antagonists. And these are reasonable to consider in patients that do have signs of fibrosis or LGE on the MRI, like Dr. Salza was talking about. It's also reasonable to start these if patients have depressed function, like depressed systolic function. So the reason why I like this medication as well is that it actually has some anti-fibrotic properties because it also has some anti-inflammatory properties. So I do like mineralocorticoid receptor antagonists. And the ones that I typically start are spironolactone or eplerenone. Now, sometimes you may see a provider, oh, can you go backwards again? Sorry. Now, sometimes you may see a provider start this if a child is over the age of 12 and if they haven't been able to tolerate an MRI. So sometimes a child may not be able to get that MRI just because it's very hard to do. So it is reasonable to consider starting one of these if by the age 12, if you're not able to get an MRI. And it's also reasonable to consider if you're seeing any signs of fibrosis based on the EKG patterns. Could you go to the next slide? Thank you. And then some other medications that are prescribed, and I was going to talk about these, are the use of glucocorticoids. And these are generally started by the neurologist to delay the loss of ambulation in children who have Duchenne muscular dystrophy. These are generally started at diagnosis, and there are various steroid preparations that have been used, like deflazacort, prednisone, and vamorolone. And so we're still kind of, as a community, trying to figure out which is the best preparation for children. Vamorolone is one of the newer ones that is being used. So generally, once these are started, we also kind of try to make sure their glucose is fine and is able to tolerate that because it is a steroid. Sometimes diuretic agents are used, and these are generally used when children have more signs of heart failure, and these are considered based on how the child is doing clinically. Examples of these are furosemide and hydrochlorothiazide. And then finally, anticoagulation agents are used at times. And these are used because sometimes some children can have abnormal heart rhythms like atrial fibrillation or atrial flutter. And when people have these abnormal heart rhythms, they're predisposed to forming clots. And so we can use an anticoagulant like warfarin to help prevent forming those clots. But this isn't done always, and so this should be done with the patient's provider and the cardiologist, and with discussion with all of with their clinical and based on their clinical status. Could you go to the next slide? So now, what if your child is still on all these medications and their heart function continues to decline and they continue to have signs of end-stage heart problems? And so there are therapies that are being considered. One is the consideration of an implantable cardioverter defibrillator, which is used for select patients that have life-threatening arrhythmias that put them at risk for sudden cardiac death. There's also the use of potential home medications that we can use that's given through an IV. And these are considered for treatment of carefully selected patients who need more medications than just the oral medications can provide. So sometimes we start something called milrinone, which is something that we can give through an IV, and it can be used for symptom control and something that they can use in the home setting. And I know Dr. Villa will talk about this more, but there's also mechanical circulatory support that's now being considered for patients with Duchenne muscular dystrophy. And so that's also exciting. And then I would say also at this stage, it's important to involve supportive care with social work and palliative care, just to help families and children as we're going through this process. So those are all important considerations to think about, especially when children are at this stage. And then finally, in conclusion, I hope that we talked a little bit today about how the cardiac care for children with Duchenne muscular dystrophy is multifaceted and evolves as the child ages. There are different stages: the preclinical stage, the clinical stage, the stage at which children have cardiac involvement, and end-stage heart failure. And our goal with providing cardiac care at each of these stages is so we can prevent them from going on to develop end-stage heart failure. I hope that you've learned that it's vital to integrate cardiac and neurology care. It can be done in a multidisciplinary setting, but also it's important to be done with an experienced heart failure cardiologist that works closely with the neurology team, because I think the integration of those two specialties and along with respiratory care is very important. Now, the future of cardiac care is improving for these children, but still a lot more is needed. We need better predictors to assess for cardiac involvement. I'm glad that we're getting more advanced end-stage therapy options for kids, but we need more knowledge of these within the general community. And then we also, as many of you know, that there's more personalized medicine developing, like gene therapy, exon skipping, and the hope of microdystrophin. So I hope that all of these will help children with Duchenne muscular dystrophy, and I hope that all of these will help their heart more. But I still feel like it's very hopeful for what's happening now in 2021.
Great. Thank you so much, Dr. Gambetta. So we have got so much good information so far. Dr. Soslow really shared a lot of great information about imaging. Dr. Gambetta gave us a really nice overview of the cardiac landscape. And now we're going to hand it over to Dr. Villa, who is going to talk about some of those advanced cardiac therapies for Duchenne.
Perfect. And I'm going to try and go relatively quickly because I think the most important part here is actually a lot of the questions that we're getting, and I managed to mess up a little bit in the chat because I was responding at the wrong time. But I think the questions are actually really great, but I'll try and go through this relatively quickly. Next slide. So as you heard from Dr. Gambetta, overall current outcomes are significantly better than they were historically. And as improvements in respiratory and neurologic therapies have really come along, cardiac therapies have really come to the fore. And that's because the heart does weaken with time. And as a result, cardiac causes of death have really started to increase. Next slide. And so what happens, as you just heard, the two big groups, while there are some other things that we tend to watch out for, really the two big things are your heart can go into an abnormal rhythm, and when your heart can actually weaken enough that you actually go into what we call heart failure, where not enough blood gets out to the rest of your body. Next slide. And those abnormal heart rhythms are actually relatively rare in the beginning. So when heart function is good, and when your sons, brothers, uncles feel good, we almost never see abnormal heart rhythms. And so we only see about less than 1 or 2% of the people will have that. We do recommend heart rhythm monitors if there are any symptoms, no matter what your heart function is, because things can happen no matter what stage, or if your heart function does start to go down, because at that point we do start to see more changes in heart function, and as boys become men and get a little bit older. And so by the time men start to have significant cardiac dysfunction, almost 40 or 50% of the Holters we find, the electrical rhythm monitors, will have some abnormalities that we can sometimes do something about. Okay, next slide. And really the big thing as we talk about, in addition to the medications that you heard about, is a defibrillator. So what that is a little monitor that actually monitors the electrical signals in the heart. And if you go into a very fast abnormal rhythm, sometimes it can actually give a shock to your heart without anybody else needing to be around. So it can detect those things very early and then give it very quickly. Next slide. So the pros are it can stop those very fast abnormal rhythms. And for some people, it can also be used with a special pacing to try and make the heart function a little bit better. Those are the theoretical benefits. The challenges with it and why we don't recommend it in everyone is people will have to be intubated because it is a heart surgery. It may not work as well in Duchenne because the heart rhythm may be a little bit different from Duchenne as it is to other types of cardiomyopathy. Also, because if there's anything that's in your body that wasn't there to begin with, it can get infected, and that can become a really big problem because now you have a little piece of metal in your body. And it may also give some shocks when it's not supposed to. Even though these newest classes of devices are very smart, they're very good, they're not perfect. And boys and men with Duchenne are more likely to have some of the abnormal rhythms that can confuse these devices. And it may overall not be as effective in boys and men who have not had a heart attack. A lot of the information and why we used to recommend defibrillators in lots of people who had heart dysfunction was because of information from middle-aged people who didn't have Duchenne and who had heart attacks. Really, the most recent data has started to question whether they're quite as effective if you haven't had a heart attack. Next slide. When it comes to heart failure, one of the challenges that we have is how do we actually detect if you have heart failure? Unfortunately, there isn't a test that actually does that. Next slide. Most of the time when we're talking about how your heart is doing, we're talking about what your heart function is. The problem is some people need less heart function than others and still can feel okay. They won't notice that anything's wrong with their heart, even if when we look on MRI or on echo, we can see those changes. Even though it's down and we have to get the meds right, it's still doing enough. The problem is some people, it won't do enough. And for some people, that might be 30%. For some people, that might be 40%. For some people, it's 35%. We don't have a perfect way, and it really comes down to how your heart and your body interact. So we try and use a number of tests, some of the labs that you heard from Dr. Gambetta, but we also look for symptoms. Are you having swelling in your body because fluid is backing up? Are you having shortness of breath? Are you feeling like you're sick to your stomach? Are you having fatigue? The problem is a lot of those things can happen even if your heart is doing okay in Duchenne. And we're trying to kind of sort out and make sense of that. And we hope to have some research soon to help kind of make some sense of that, both for patients with Duchenne and for families and caregivers. Next slide. And really the biggest part, and this is really, really important, even though I've talked a little bit about defibrillators and I'm going to talk a little bit about heart pumps and VADs, the most important thing that we can do is actually get on medications early, optimize those medications, because the 99% of my job and the best part of my job is keeping people out of the hospital and not having to do any of these things. If we do need to do it, we want to make sure that people with Duchenne or dystrophinopathy in general have access to these therapies. And that's why we're talking about it a little bit. Really, the quote from Benjamin Franklin, I think, is extraordinarily important here. An ounce of prevention is worth a pound of cure. That data that you heard from Dr. Soslow, that there's early fibrosis, there's a potential to intervene there, but later in the disease course, when it becomes fibrofatty changes in the heart, it becomes very hard, even with the best medicines, to go back. We need to get ahead of the game, use that, and then we get to some of these advanced therapies that we want to have access to, and we do have access to now. Okay, next slide. And so when heart failure does start to develop, even when medications have been optimized, we will use what we call a VAD, or a ventricular assist device. This is Susie, who many of you knew from before. She was one of our patients here in Cincinnati, and she was one of the first carriers who received a heart pump. And what that is that little thing that's in her hand was actually implanted in her heart to help the blood pump around her body because her heart wasn't doing it anymore. Next slide. And I don't want to get into the specifics of exactly how that works, but the thing to know is when implanted at the right time, it can improve symptoms of heart failure. That's the only reason we do it. And it can make people feel significantly better, but not everyone. The outcomes are also improving with the newest devices that we have. We are getting better and better year over year with these pumps. And as you're about to see, we are putting them in more patients with Duchenne, Becker, carriers, and muscular dystrophy in general. So I'm a huge advocate for having access to this, but the cons are worth talking about. And this is why it's not for everyone. Again, it requires intubation for surgery. So if your lungs are very weak, the heart pump is not going to make those better. The big thing that we worry about really from a heart pump perspective is anything that's artificial in your body can get infected or can cause your blood to clot on it, and that can lead to a stroke. And those two big things are the main reasons why it's not for everyone. And in fact, most of the people that I see here in Cincinnati have not gotten a pump. You'll see some numbers, and we're doing them more and more, but that's because it's not for everyone. You can go to next slide. And so how are we learning how to do this best? As you heard from Dr. Gambetta, Action is one of a group, and Dr. Soslow is also a part of that group where we're trying to learn together about how to care for men with Duchenne's. We got, I think, pretty good about taking care of young kids and teens, and we're only just learning how to take care of men with Duchenne's, and we're trying to learn how best to apply these therapies, the ICDs, those defibrillators, the VADs, how to optimize our medication dosing, and also to interact and ask our families and our men as they get into their 20s and 30s, and they can say very eloquently, here's what I want to do. Here are the things that are important. Do you have ways to help me with those things? Next slide. And as it relates to it, this is a little bit of research that PPMD has funded, and this is our initial experience looking at the use of VADs in patients with muscular dystrophy. So 18 patients over the last 8 years, the vast majority of those had dystrophinopathy. So as you can see here, of those 22 centers, 8 have been placed in patients with Duchenne, 3 with Becker, now a 4th because we have put one in, and then 1 carrier. And really the biggest point here is we are starting to learn together, and we are starting to give families and patients the option if we think it's the right thing. And as you've heard me say over and over again, I think really the important part here is that you have access to these. You can talk about a defibrillator. You can talk to people who have put one in. You can, same thing from a VAD perspective, because it's not right for everyone. But I do think when you get to that point, you should be able to talk to someone who can give you the option, talk about the pros and cons, and talk about your son, brothers, their heart, and say, is this the right thing for you? Because I think really the big problem that we had before is no one was giving the option at all. And that's the only thing I can say is the wrong answer if you aren't able to talk about it, because just because you have Duchenne, and that's what gets me fired up, and it's part of what drives me to do what I do. Next slide. And so really the takeaway here, this is Ricky, one of our patients, is really defibrillators are there for the abnormal heart rhythms, VADs are there for heart failure, and we're still learning how to use these devices. And really that you should know that this option exists out there, even if it may not be right for you or for your family members. Next slide. And the final thing is, and this is going to be one of the things that I think we're going to talk about, is what are the overall outcomes right now? The answer is it's actually being written right now. Outcomes are improving day over day. And we're trying to learn with you guys as things go along. And we're trying to rapidly disseminate that both to families and to other clinicians so that we have access to all of the therapies as they come out. I think that's it.
All right, thank you, Dr. Villa. So at this point, we'll just go back to the heads up display and we'll dig into these questions. I see some really fantastic questions that you've all submitted so far, so keep them coming. We are able to go until about 2:30 or so I think we should be able to get through hopefully all of them. Dr. Villa, I know that you were able to address a couple of them in the chat, but maybe we can just kind of bring that back up and discuss as a group. So I'm going to start at the very top. I know that Dr. Soslow, you talked a little bit about this in your portion of the presentation, but maybe you can talk a little bit more about why we can see differences in ejection fraction measurement on MRI versus echocardiogram.
Yeah, sure. That's a great question. And so I think the first thing to realize that if I hold my fist out and pretend like that's a heart, when we're measuring things on echo, we usually use 1 or 2 planes. So just slice it like this to get a sense for the entire function of the heart. And the heart can move together, or it can move where some parts are moving well and some parts like right here aren't moving well at all. And so we're using geometric assumptions essentially on the echo to get a sense of what the function is. And those assumptions depend on, first of all, us seeing everything that's not working well. And second of all, us seeing the heart well in the first place. And as we said, a lot of times we just can't see the heart well. And so they break down if there are wall motion abnormalities where the heart's not moving the same in every place. And they break down if we just can't see the walls. When we use MRI, we can see really well, and we also go by slice all the way through the heart and use that to reconstruct the ejection fraction. So it's much more accurate in general, but especially in patients with bad function or with bad windows or with different wall motion abnormalities, which we often see in Duchenne patients, we can have discrepancies between the echo and the MRI measures. And so that's why essentially is we just get much better pictures with MRI, and we do a more comprehensive evaluation with MRI.
Okay, so I have another question of my own then on that same topic. So in an older patient, so in an adult with Duchenne who doesn't tolerate getting in the MRI and has really crummy windows, can you maybe talk through what that sort of algorithm looks like for you and how you optimize care for someone where you don't have a really great image of their heart function and what's going on?
Yeah, that's a great question, and it's something we struggle with a lot. What we've been able to do for some of our patients is a shorter MRI where we're able to get them in the scanner if it's claustrophobia or discomfort, and do like maybe a 20-minute MRI or even less where we just look at function and don't give any contrast. And we're doing a lot more of those non-contrasted scans, at least have been over the last five years, to limit contrast exposure anyway. And if that doesn't work, then we spend a lot of time with positioning on the echo and really try to get them in a better spot and try to get any window we can. And sometimes we found that working really hard, we can get enough pictures to see what we need to see. We can do CT scans for people who have pacemakers and for that reason are unable to get an MRI. But we have not, I can't think of anybody with Duchenne that we've done that for in our center. We would consider it because we have a pretty low dose radiation CT scanner that's about the same dose as an X-ray. But unfortunately, it's more just getting the best pictures we can with echo. Catherine and Chad, I don't know if you have any other tricks you've used.
Times we've done, we're starting to do contrast echo when we have like patients that can't tolerate the MRI, or if they have really difficult windows. So what that involves is like placing an IV and using different contrasts. I think we have like Lumason and Optison. And so we use that. And so basically what happens is an IV is placed and it's infused through the IV. And then that actually kind of, that contrast kind of highlights and fills the ventricle, and it highlights the whole ventricle. So you can kind of see what the borders of the ventricle look like, and you can get a better assessment of their ejection fraction. So we're starting to use that more.
I think
thanks. I should have mentioned that we don't have a protocol yet for our contrast echo. We're working on that right now. So we'll probably touch base with you to make sure that we're using the right protocol, because we've been trying to get that up and running.
And I think the important part that you're hearing from us is these are important adjuncts. It's really important to generally see how your heart function is, but ultimately, especially when you get older, we will optimize medications independent of what the heart function shows. And I think that's an important part of understanding you can still move forward with your medical therapy, even if you can't optimize all of these other things. We do the same thing as you've heard, which is we do an MRI once a year. We'll do gadolinium every couple of years. We'll do echo otherwise. But even if those things don't work, you should not have a delay in your therapy. We should be able to have a cardiologist who's used to taking care of Duchenne and can find ways to work with you to get the right therapy, even when those things aren't ideal. And I think that's really important.
Great. Thank you so much, all of you. That was super helpful. I've got a couple of more imaging questions, and then we'll move on to some additional questions that we've got in the chat. So this is kind of a twofold. So in regard to the MRI, how often is it safe to perform an MRI? And then are there concerns with gadolinium accumulation over time?
So the MRI itself really is safe to perform as often as you want in terms of magnet exposure, that sort of thing. It's a very safe study. The gadolinium contrast question is a really good question. We could probably spend about an hour on that if we really wanted to. It's been something we've talked about a lot in the CMR community for the last couple of years. So there, just for some background, there was some data. There are data showing that gadolinium can be deposited in the brain. We've been trying to learn more and more about that. The FDA put out a black box warning about it. And even before then, we were limiting our contrast administration for everybody. But since then, we've been really careful to only give contrast to those we need to give it to. Now, there are a couple of things about that. The first thing is most of the patients that they found it deposited in, at least initially, had tons of brain MRIs because of brain cancer. And so they were getting a lot of gadolinium. It's certainly been shown in patients with less than, say, 10, 20, 30 scans, but it was initially shown in those patients. The other thing is nobody's ever figured out a problem associated with that. I don't think anybody's excited about it because nobody wants to have gadolinium in their patients' brains or in their brains. But there's not been any problems associated with it, which is a good thing. The last thing to know is that a lot of the data that has emerged, including data from our center and others, is that it really is not seen very often in kids, especially with the contrast agents we're using now. And so people with good kidney function and with what we call multi-cyclic gadolinium contrast agents, it seems to be much less common to see any brain deposition. And so when we looked at it, our study, we didn't see anybody in our cohort with or without Duchenne with brain deposition. Now, those are all patients who happen to have a brain MRI, but it was a pretty good number of patients. And then, you know, as these things have emerged, that it does seem like it's less common than usual. It's been a little bit less of a concern in the CMR community lately. We still limit gadolinium, like I said, and like Chet said, we'll do non-contrast scans. We get gadolinium more in the younger kids as we're trying to see if there's enhancement and see if it's progressing. But once we have enhancement, and especially once we have significant enhancement, we very rarely add the gadolinium because we don't think it adds as much as knowing what the function is. But we've seen patients with 4, 5, 6 MRIs with no gadolinium deposition. And we feel pretty comfortable that a small number of scans, like in that 6 range with contrast, are probably going to be okay. But we're always very cognizant of any risks associated with things we do.
Awesome. Thank you so much, Dr. Soslow. Dr. Gambetta, Dr. Villa, anything you want to add to that? Okay. All right, so we'll go ahead and go on to our next question now. So this is one that I think I'll field to you, Dr. Gambetta. So let's talk a little bit about the ideal age for boys with Duchenne to start cardiac meds. So we know what the care guidelines say, but I know that this is a really hot topic, particularly consideration for starting earlier, even in the absence of abnormality on echo or MRI. So let's talk a little bit about ideal age to start and when you might consider deviating from that typical way of prescribing.
Yeah, thank you. It's a great question. I would say that it's something that's, like you said, it's been debated about and talked about for a long time. I think the goal of starting the medication early would be with the hope of delaying the onset of progressive cardiomyopathy and hopefully delaying the onset of heart failure. We do know that some children, even very young, because of that lack of dystrophin or that lack of sufficient dystrophin, they do have, there have been seen some abnormalities in some echo parameters called strain measurements. So we do know that they are at risk for increasing wall stress. And as we know, like they're having ongoing, muscle breakdown. So I would say from my end, I tend to start it early, around 8, but I would say I agree that I think by the age of 10, all boys should be on these medications because the goal of the medication, again, is to preserve heart function for as long as possible because we know that they have some ongoing breakdown of their muscles. And so my goal with the medication is to decrease that wall stress to try to, decrease any adverse remodeling that can be happening. And the hope is that with this, they can, have preserved heart function for as long as possible. So, so I tend to start at, around 8, but I would say definitely by the age of 10, all boys should be on it. There are some people that conjecture that maybe even starting it sooner. I think just when I was talking with some of my neurology colleagues, one of the questions that had been raised was, and this is a little bit, it's a lot of discussion, but hopefully at some point we'll have some potential for newborn screening of this, so we can kind of identify children even sooner than how they're being identified now. And the goal would hopefully start, potentially therapies even sooner, like especially with the gene therapy and exon skipping therapies that are being developed, that hopefully you can even start those even sooner, so you can even prevent any fibrosis that can occur in the future. So that's something that's being debated and talked about now with my neurology colleagues. But I do agree. I think that starting these medications earlier to prevent fibrosis, and at least to decrease fibrosis before we see any overt signs of decreased heart function is important.
Great. Dr. Villa?
And I think the important part is talking about where some of that data came from. So there have been a couple of studies that I think are really important. A couple out of France that started initially with the perindopril study that showed that it can slow the progression of cardiac dysfunction and heart failure. And then a second one that came out of Brazil. That one out of Brazil was really important because they used MRI to show that in patients with Becker and Duchenne who had relatively preserved heart function, but who had LGE, they could slow down the progression of that LGE. And then there was a study that just came out of France 3 or 4 months ago that followed a couple of 100 patients over a very long time in multiple clinics in France. And they showed they were able to really significantly slow the progression to heart failure. And that was in patients who were started after that perindopril study and were started on things before their heart function went down. And so that's where you're starting to hear more and more of, should we start earlier? The specific answer of when to start, we don't know the answer. When we look at MRI studies, we see about 10 to 15% of boys will have LGE on their first MRI. So a lot of that data came out of initially here, and then also out of nationwide, and then some from Dr. Soslow as well. So the boys, when they get their first MRI, will actually have LGE already. And that's where that question is starting to come of, is there a too early? And the answer to that is, right now, we don't know the answer to that. We're trying to figure that out. We're trying to develop other markers to try and understand, should it be 6, should it be 8? But right now, the feeling is ahead of the data, and we're trying to answer that very quickly. In general, the conversation we have with our families is, we will start by age 10 if we see nothing. If we see anything earlier, we will usually start an ACE inhibitor. And if there are other abnormalities or other specific concerns, we'll at least have a discussion with the family and talk about how we're going to monitor to make sure it's safe. But the answer is, right now, we're still understanding that, is there a too early?
Excellent. Thank you so much, Dr. Villa. I'm actually going to field this next question to you too. I really like this next question. That's quite pertinent considering, Dr. Villa, your work with the guidance. So in your view, what are some of the main barriers to establishing endpoints which will be acceptable to the FDA? And how long do you expect this to take?
How long do I expect? I'm going to punt that one. We're going to try and push a bit harder because we have a couple of pieces of data that we're hoping can let that come out. But the reason why is, in non-Duchenne, cardiomyopathy, it turns out your ejection fraction and how you do and whether you have heart failure doesn't always go together, because lots of adults can have what we call HFpEF, which is a fancy way of saying you have heart failure, but your ejection fraction or your squeeze is okay. And so the FDA says you can't just use ejection fraction because that doesn't always matter in terms of symptoms and who does everything. Well, that applies when you don't have Duchenne. In Duchenne, we have a couple of things that are important. That data that you saw from Dr. Soslow that show as your ejection fraction goes down, your risk of cardiac mortality actually is pretty linear and starts to go up. And then the other thing for data that we're hoping to publish soon, when we take those VADs, we actually get a little bit of heart tissue. And what we're seeing is, in older men, and even in younger men who have severe disease, it turns out it's not just fibrosis that we see on MRI, it's fibrofatty replacement. The heart, just like the skeletal muscle, actually has fatty replacement of the heart. And so we're going to come back hopefully to the FDA and say, that all made sense when you're not talking about Duchenne, but in Duchenne, we think this is a pretty good marker, and we're getting more and more data that this might be right. We just have to build that evidence. And actually, this is where PPMD and actually working with Dr. Gambetta and Dr. Soslow is really important. We're working together to get this answer. We couldn't have gotten that in a single center, but we're getting the support that we need to actually come together, pool our information, and say, we have better data, and now we need to reassess this because we need to intervene early and use different markers for Duchenne, because it's not like everything else. You guys already know that with your boys. We just need the FDA to understand it.
Yeah, and I think to add on to that, that's really what our 6-center study is doing, that Lori's in with Catherine. We're part of a study that the FDA is funding, looking at ifetroban, and what the outcome measures are, LVEF and strain with delayed enhancement as a secondary outcome. And that's funded by the FDA. So our hope is that with the data that we're trying to get out and with that study, that we can push them to accept these as adequate endpoints in Duchenne.
Excellent. I'm learning so much today from all of you. This is just really, really rich conversation. So my next question I'm going to pose to you, Dr. Gambetta, to start us off. And this is a question that I've been hearing from the community a lot lately. So it reads, are you starting to prescribe Entresto or those kinds of medications developed to help diabetes patients, which might also help address the development of fibrosis?
That's a great question. So I know there's, so in terms of the Entresto, I am starting to prescribe Entresto to certain select patients. But again, like, we still need a lot more data about that, a lot more experience with that. And I think there isn't that much robust experience with the use of Entresto in the community for Duchenne muscular dystrophy. We are just starting to use it more in pediatric patients who have cardiomyopathy for different reasons. So, but I have used Entresto for select patients when when they do have signs of severe heart dysfunction, when their ejection fraction is pretty poor, I have started to use Entresto in place of lisinopril. So Entresto has been used more in the adult world, and Entresto is a combination of 2 medications, sacubitril and valsartan, and so it's a combination of 2 of those things. And there has been good success with it in the adult population, where in terms of symptomatic relief from heart failure symptoms. So in terms of pediatrics, like I have had experience with that, and I have used it in some of our patients with Duchenne muscular dystrophy. But again, there's not too much data out there to show if it's superior to what we're doing right now. And I think that's one realm in which action will be helpful with. In terms of the other medication, the diabetes medication, the SGLT2, I haven't used that much, but I know there's more data out that in the adult population of patients who have heart failure. So I don't have as much, I don't have any experience with that. I'm not sure what experience my colleagues have with that.
So I think we've used Entresto. We will generally consider it in patients who have an ejection fraction less than 40%. The biggest problem that we've run into is blood pressure. So both of those medications are that combo that you heard are both for blood pressure. And for a lot of our older men, blood pressure is an issue anyways. So that's been one of the limiting factors, but we will consider it in everyone who has an ejection fraction less than 40% from an Entresto perspective. We are just starting to use the SGLT2 inhibitors. And again, we use a similar cutoff in terms of injection fraction less than 40%. It generally tends to be pretty well tolerated, even though it was developed for diabetes. It has become obvious that it helps in non-Duchenne heart failure. And as a result, we've used it, but we acknowledge that that's all coming from non-Duchenne based.
Yeah, we have not yet used Entresto and are kind of excited about the SGLT2 ones, just because of the data emerging in adult, but have not used it yet. I think they might tolerate it better, because one of the reasons we haven't used Entresto is most of our patients who would really qualify for it have low blood pressure, like Chet was saying, and so it just felt like switching them might not be in their best interest if they were going to be hypotensive.
Great, thank you so much. That's really helpful. Like I said, this is something that has come up quite frequently lately, so I really appreciate the candid conversation around its use. So let's shift to gene therapy briefly. So any sense of current microdystrophin therapy cardiac benefits? I'm not sure that we have a straightforward answer, but I would love to hear your initial thoughts on this one. Who wants to start us off?
This one is easy from my perspective, which is we don't know. I think for a lot of, this is going to be the answer for a lot of the things that were developed from a skeletal muscle perspective. And I think it's actually a really important question, and we have to continue to watch the people who have received these therapies. That's the first point. And then the next point is we have to make sure that if you received any of these therapies, we're still going to be considering you for what we hope to be a couple of cardiac trials as they come out over the next couple of years. And this is really going to be fundamental into understanding what these therapies mean, because it is plausible that they may help from a skeletal muscle perspective, but not help from a cardiac perspective, or they may help with both. The answer is we don't know. We need to watch, and we need to share data to be able to understand that as fast as possible so we can feed that back to you guys.
I agree with that. I think there's still so much that we don't know, and it's promising, but there's still so much that we don't know about how it'll affect the heart. And like Dr. Villa was saying, like it could potentially help the skeletal muscle, but then not help the heart. And so one of the concerns is if it helps the skeletal muscle, could this potentially cause more boys to become symptomatic with symptoms of heart failure because they're doing more things and they're more active. So could that potentially maybe exacerbate the heart? But we don't know. But could it also help the heart? So it's very interesting. And I think we're all excited to kind of figure out how it's going to help the heart. And, you know, I guess when these microdystrophin is made, there's a certain portion of it that attaches on that has like a certain protein called MYH7 that the microdystrophin is used to kind of get some heart effects, but what we don't know really how that will be. So it's very exciting, and I'm excited to kind of learn how it's going to affect the heart if it does at all. And I'm hopeful, but we just don't know. And so when I do see kids that are on microdystrophin that did get the therapy, the microdystrophin therapy, I actually just continue my current cardiac care that I typically do for any child that where I start an ACE inhibitor by the age of 10, and I still get the cardiac MRI, and I still do all the things that I would do before. So even though they're even though they receive the microdystrophin, I still continue with my current cardiac care.
Great, thank you so much, Dr. Gambetta. We have so much to learn here. So let's pivot a little bit to a different subject, but I think it's a really important one too. And I'm not sure who should start us off, so I'll just field it to the whole group. But we've got a series of questions regarding manifesting carriers, particularly those who are adolescents. So I think maybe the best way to approach it is let's talk a little bit about cardiac manifestation of carriers and how do you approach them differently? How do you approach them similarly to a typical case of Duchenne? Let's just talk a little bit about how you think about care for your carriers.
I can start just from the imaging standpoint. As I said, Conhor and Mei-Ling Ma have done a lot of stuff in carriers and research, and they published something a couple of years back showing that in the population they looked at, which was an average of about 40 years of age, they had, I think 50% of them had delayed enhancement by the time they imaged them. They also showed some exercise abnormalities, and those were related. They were sort of some arrhythmia events, some PVCs and recovery, sort of as recovering from exercise, and that was related to the delayed enhancement. So the people with delayed enhancement are more likely to have those. And so that being said, I don't take care of adults, and so I don't see the moms. I just mostly see children with who are carriers, and for them, depending on the family history, I'll see them every 1 to multiple years. I have some patients whose moms actually manifested really early, and I've been following them more closely because of that. But for the most part, I see them every maybe 2 years, maybe less frequently, and screen them with echo and then get an MRI when they're old enough to get an MRI, just to get a sense of what's going on. And I'll pass it to Chet and Catherine.
So from my perspective, I think that's what we use MRI, and especially if you're older, into your 20s or 30s, we would recommend every 3 to 5 years, depending on the family history and the other stuff, if the MRI is normal. If it's not, we actually go through in a very similar clinical approach in terms of saying, if you have LGE, it would be reasonable to consider an ACE inhibitor and aldactone, but we really don't know the answer to how effective those are. We believe that it's probably going to be so, but we can't tell you the same. We don't have the same level of data as we do for our boys and young men. And it has become, the other thing that's really important, well, two things. One is, even though we take care of some older women, eventually they get so old that we can't take care of them in the children's hospital. We can't provide effective care. And so in those situations, what we think is really important is actually finding a cardiologist who we can then talk to. So what we do in those circumstances is we'll provide a little bit of extra information for women to get their cardiologist to call us. And we say, first of all, don't go looking for a heart attack if you see LGE in this situation, because that, for somebody who does not know somebody's a manifesting carrier, they'll see LGE and worry that something else is going on. And we say, nope, this looks like it's in a typical pattern for a manifesting carrier. So don't do anything too crazy. And here's what we think is going to happen. So we try to provide a little bit of help in that regard. But if things are manifesting earlier, so teenagers or Susie in the situation from our from my slides, is we treat them the same way. We definitely optimize medical therapy as early as possible, and we continue to consider all of the therapies that we have in our armamentarium.
I agree with what John and Chet were saying. I think so I guess to start off with, first with mothers, I do, when I meet the child and their family, I do recommend that mother gets follow up with a cardiologist. Even, it's kind of interesting, even today in clinic, there was a mother who was difficult for her to get cardiology follow-up, and she lived far away from a center. So from a center that knows how to take care of adults and children with neuromuscular disorders. And it's kind of surprising that even now in the adult community, that adult cardiologists they're not quite aware of female carriers of Duchenne muscular dystrophy. And so they don't quite know like how to approach these things. So I do think it's important to kind of help mothers find cardiologists, or that you work with your adult colleagues that take care of adults with neuromuscular disorders, to kind of guide them in the right way. Because I do feel that sometimes mothers don't quite get as much care as they should. So I do try to kind of provide some recommendations in terms of that, and to help them with that. Then in terms of children, females who are manifesting carriers, I agree with my colleagues too. I think it's hard. It is hard, but I do feel like one thing that would be helpful, that sometimes that is helpful, is kind of knowing how much inactivation of their gene that they have, that has how much of their gene, their X-linked gene that they have that's inactivated. Sometimes that can help, but I do feel like with the manifesting carriers, I kind of would treat them kind of like a child who has, like a boy who has Duchenne muscular dystrophy, and provide the same kind of care. If it's a child that's a carrier, I probably, but not manifesting as much, I probably would get screening echoes and EKGs maybe every 1 to 2 years, depending on what I find. And if I find any signs of fibrosis or LGE or dilation, I may start therapy on them. But it's interesting. I think manifesting carriers are an interesting population of patients that we're learning more about. And I think that they are a special set of children that, sometimes get forgotten a little bit, but I think it's, but I do continue with our current therapy that we have for dystrophinopathies for these kids.
The other
Great,
thing
thank you.
that's worth noting for carriers is one, for the carrier moms out there, is you got to listen to your symptoms. So even though we mostly talk about the ventricular abnormalities on MRI, we have data that the atrium, the upper chambers, are also affected, and we're seeing more what we call atrial arrhythmias or upper chamber arrhythmias. So if you don't feel your heart beating normally, you should get it checked out, because we've started to appreciate some abnormalities that can happen there, even when we don't see LGE on the MRI. Generally, they tend to go together, but I think most of the moms that come here do everything they can for their sons, and they don't pay attention to themselves. And so if you have symptoms, it's actually really important to talk about, because I think we do have therapies for it, but you maybe put everything into your sons, and sometimes you got to pay attention to what you're feeling.
That's
Absolutely.
true. That's really true. I think sometimes mothers just forget to take care of themselves, but the only way they're going to take care of their children is if they take care of themselves too.
Isn't that the truth? So I want to be mindful of time. We've got a little bit less than 10 minutes left together. So I'm going to ask one more quick carrier question, and then we've got a couple other questions after that that I would love to touch on before we wrap. So from a cardiac perspective, in regard to female carriers, do you ever recommend imposing like activity restrictions or limitations because of potential cardiac involvement? Dr. Gambetta, do you want to start?
That's a great question. I guess it depends. It depends. I know that our physical therapists in clinic will see some of these children, and I know they have like certain types of exercises that are more recommended, like eccentric exercises preferred over other types. But from a cardiac perspective, if their cardiac function is normal, I don't, or if their cardiac function is fine, I don't. And I kind of let them kind of self-limit themselves if they don't have any cardiac concerns. I kind of let them self-limit, and I don't impose any type of exercise restriction. I think physical activity is good for children from a physical perspective, and from a cardiac perspective, and from an overall social and emotional perspective. So I don't put any restrictions on them. I'm not sure what my colleagues do, so it'd be interesting to know.
I think I'm pretty similar in terms of carriers. If they have delayed enhancement, then I will start to talk about limiting from competitive sports and really strenuous activities. But I'm not sure that that's come up before. But I would probably, that'd be my only exception to what you said. Otherwise, I agree. I think activity is better from a heart standpoint, and I like to have my patients moving.
I think one of the questions that came up is about marathons, and I think the answer is we don't know the answer. And in fact, when we look at marathoners in general, not even carriers, we can see evidence of LGE and what we call ECV abnormalities. So there may actually be some damage that happens for people who ultra marathon or marathon anyways, but there's not enough data. If it is what drives you, my answer is, if I can't answer that question definitively, and it is what you love to do, you should do it. If I have data along the way that changes that, then I'll recommend it. But right now, I don't have enough information. And if it's what drives you, you should do what you love until I know it's not right.
That's fantastic. Thank you so much. Okay, so last couple of questions. So this next one is about ACE inhibitors versus ARBs. So when do you choose ARBs as first line? I saw a recent presentation that indicated that the Duchenne population might do better with ARBs over ACE inhibitors. Who wants to start that one for us?
I'll take that one. The answer is the best head-to-head data came out about 10 or 15 years ago, and it didn't suggest that one was had an advantage over the others. It's actually going to be really hard for us to answer that clinically because of the variability that happens. So I think it's going to be very unlikely that we have a, hey, here's the best scientific study that can answer that question. We have generally preferred ACE inhibitors here because the most data is out there on ACE inhibitors, but we will switch over if people don't tolerate it because of cough or from other reasons. But right now there isn't any data that suggests that one is significantly better than enough to make that difference from our center's perspective.
Yeah, I agree with that too. I think I generally start with ACE inhibitors, and the data has been shown in ACE inhibitors, but I will switch to an ARB if there are like other side effects from the ACE inhibitor. Like if a person has a really persistent dry hacking cough, or I'm not tolerating it, then we'll switch to I'll switch to an ARB.
Dr. Soslow, do you want to add anything? Nope. Okay. All right. So I think this will be our last question, and it's a really good and timely one. So the question is, how would you monitor an older person with Duchenne if you're concerned about potential adverse event from COVID vaccines or booster shots? So I know that the concern about myocarditis has come up both in active COVID infection and, rarely post-vaccine. So any thoughts or commentary on that?
This has come up a lot in clinic for us, and we've spent a lot of time dealing with COVID myocarditis in general and post-COVID vaccine myocarditis. And I can tell you that the last data I've seen overall, the risk of COVID myocarditis is very low. The risk of myocarditis after COVID vaccine is very low. I think in the overall population, it's somewhere near 1 in 100 or 1 in 50,000. And in this age group, it's probably more like 1 in 5,000, but that's still extraordinarily low. The risk of myocarditis after getting a COVID infection is higher than the risk of getting myocarditis from the vaccine. And also in Duchenne patients, given the respiratory issues a lot of our patients have, the risk of getting COVID is much higher. If you just take out the myocarditis entirely, the risk of getting COVID is much higher than the risk of the vaccine. So we recommend that everybody get the vaccine and get the booster just in order to help protect them.
Any thoughts on recommending additional monitoring regardless of vaccination or infection as far as potential either post-infection or post-vaccination myocarditis? Are you educating about certain symptoms to look out for, or anything like that?
Yeah, I mean, we would just say the same monitoring we were recommending for all kids, and for all pediatricians to do. So chest pain, palpitations, faster heart rates, fatigue. Chest pain really seems to be the biggest in terms of the presentation, that and some shortness of breath in terms of the post-vaccine myocarditis patients that we've seen. So if you have symptoms after the vaccine, we definitely recommend that you get seen and call either your pediatrician or call your cardiologist. The most common timeline is within 2 weeks after the second dose of the vaccine. And most of them are actually with less than 7 days or even in that 1 to 3 day range of the second vaccine. But it can happen after the first vaccine. Most of the time it happens if someone has actually gotten COVID, whether they know it or not, and then get the first dose of vaccine. It seems like there's some sort of priming effect, and then you get the next dose of vaccine, or you get exposure, and then you have the post-COVID myocarditis. So those are all things to keep into account. Also, it seems much more common in younger males. So obviously the population that we're discussing today in terms of Duchenne. So all those things are things you should look out for, and please contact someone if you have symptoms afterwards.
Dr. Villa, Dr. Gambetta, any other thoughts to add to that? All right. Well, I just want to thank all three of you, Dr. Soslow, Dr. Villa, Dr. Gambetta, for joining us today. This has been an incredibly rich conversation with some amazing insight to the wonderful questions that our community has submitted with us today. I know I personally have learned a lot. I hope that everybody listening from home has learned a lot too. We love having these interactive opportunities available and bringing the community and the physicians together in this space where we can just ask these questions that are burning, that, we think of them, in between visits, or we forget to ask them at visits, or we just need this open forum. So we're really appreciative for you joining in and lending in your expertise. For everybody that's listening at home, a recording of today's webinar will be available for playback on the website if you had to jump out for a minute, or if you have any friends or family that would like to take a listen. So we should have that available within the next several days on our website and our YouTube channel. And thank you again for everybody who joined us. This was a wonderful hour and a half, and that'll conclude today's recording. Thanks so much.
Thank you so much.